Welcome to this presentation on late onset epilepsy and subsequent stroke risk. My name is Dr. Jasmine Wall and I was supervised in this project by Professor Emsley. I have academic affiliations to the University of Lancaster and received a bursary supporting this presentation from the Association of British Neurologists. And as neurologists, we are interested in epilepsy for two main reasons. Firstly, because seizures are intrinsically problematic to patients, but also because seizures tell us something about the brain, what stresses the brain has undergone, and what might happen next. Over the course of this presentation, I hope to convince you that in the case of late onset epilepsy, seizures tell us that patients are at over a threefold increased risk of stroke after the onset of late onset epilepsy. This is important because we have the opportunity to intervene and to prevent stroke in these patients. The Atherosclerosis Risk in Community study recently published that patients with seizure onset after the age of 60 have a 1.5-fold relative risk of diabetes and a 1.3-fold relative risk of hypertension compared to the background population. These are patients with an increased burden of cerebrovascular risk factors. I will discuss 5 large studies focusing on the risk of stroke after late onset of epilepsy. Post-stroke epilepsy has been excluded from this presentation. As we all know, patients who have experienced stroke are inherently at a risk of increased stroke. I'll bring these 5 papers together through meta-analysis to show that there is a statistically significant and clinically meaningful increased risk of stroke in these patients. The first study in this area was performed in 1987 in Birmingham and was a case-controlled trial. Intracerebral hemorrhage and ischemic stroke were both included, which is also common to all subsequent studies. In 2004, a study in Glasgow went on to use clinically coded GP data. This study excluded drug and alcohol use, which might themselves be considered to be cerebrovascular risk factors. In 2014, a large Taiwanese study used national-level insurance data. Additionally, this group stratified by age to show that the group with the highest relative risk of subsequent stroke was in fact aged 20 to 39, with an 8.9 hazard ratio compared to peers. In 2015, a study in Carolina used clinically coded hospital data, again to look retrospectively at epilepsy risk preceding stroke. And most recently, in 2017, a study based on the Swedish Rikstroke National Stroke Registry performed a large study, and the large case number is due to the use of the national background population as a control group. Additionally, they observed a non-statistical higher proportion of seizures in intracerebral hemorrhage compared to infarcts. Individually, these studies contain their own strengths and limitations, but collectively, when I performed a meta-analysis of these studies, a clear picture emerges. Cumulatively, using a random effects modelling, the weighted odds ratio of stroke in these studies is 3.7, with a 95% confidence interval 2.7 to 4.8. How does this fit a bigger picture? Well, it strengthens the hypothesis that late onset epilepsy represents a prodrome of early symptomatic cerebrovascular disease, which heralds subsequent stroke. And not only stroke, although epilepsy is a well-recognised feature of advanced Alzheimer's dementia and vascular dementia, in some cases it might represent the first symptom. In truth, there are no high-quality studies dedicated to understanding the natural history of late-onset epilepsy. What are the clinical implications of all of this? We all know that these patients have a high prevalence of vascular risk factors, and we have evidence that this population goes on to experience a high incidence of subsequent stroke. This makes a diagnosis of late-onset epilepsy a unique point at which to screen for cerebrovascular risk factors. I've been asked before whether there is evidence to support the use of antiplatelets in these patients. Without understanding the relationship between late-onset epilepsy, ischemic stroke, and the possibility of hemorrhagic stroke risk, it's difficult to make evidence-based recommendations. There are also limitations to the nature of existing evidence. Non-dedicated, clinically coded datasets are intrinsically limited by hermeneutic or interpretive challenges. For example, if Todd's paresis were to have been miscoded in the emergency department as stroke, this would confound the data available. I hope that we might come to understand more about later onset epilepsy and stroke risk, but I expect that further progress may need to come from dedicated, prospective data. The single message from this presentation is that patients with onset of epilepsy, even as early as 20, are at an increased risk of subsequent stroke. It's pertinent to be proactively identifying and modifying cerebrovascular risk factors such as smoking, hypertension, alcohol, illicit drug use, and diabetes. Later onset epilepsy is fertile ground for research when it comes to the prevention of stroke, so watch this space.